Thank you very much. You guys presented a really good arguments, and you're killing me. So I'm going to talk about the past, present. You talked about the past. The present is your patient comes in, BMI of 26.5, okay? Has got fatty liver, so they have excess adiposity. Can you give them tirzepatide? No, because that's not the indication of tirzepatide. So currently in the environment that we're in, BMI is really important. But of course, it doesn't tell us about the pathophysiology. So there's nothing but either good or bad, but thinking makes it so. So they both have the benefits and the utility, and both of you have described it well. And because BMI is such a troublesome measure, you'll see all these different measures. And in fact, nobody can measure waist circumference really well. It's bad enough to get BMI measured correctly. And if some people can't do the height right, so just imagine trying to do waist circumference, and it's very messy. It's really hard to do. Uh, and generally, when we start, we talk about obesity, and then we think about complications. But I want you to look another way, but think about the complications and say, is there an underlying adiposity? And maybe we need to think of it this way. And when we look at the underlying adiposity, then it's go and search for it. Where's the problem? What's happening to it? So if you start with the complications, some of it is due to excess adiposity and inflammation that's going on, but there are all these other factors we should be talking to our patients anyway. So we should be talking about diet to anybody, no matter what their BMI or body composition is. We should talk about sleep, etc. And of course, we should never give them medications that create obesity and excess adiposity. We're very good at giving gabapentin and all these drugs that actually make people put on weight, steroids. So we really need to think about what we're doing. I want to look at obesity a little bit like the thyroid. Obesity is a disease of adipose tissue. You could have absent thyroid, you could have absent fat. That gives you lipodystrophy. You can have a goiter, and you can have mechanical problems of obesity. And as mechanical complications may not necessarily be related to cardiometabolic mortality, but they certainly affect that patient's quality of life. You can be hypothyroid, so you got anorexia, for example. There's very little fat, there's little menstrual cycles, risk of osteoporosis, etc. And then you have hypothyroidism, where there's inflammation in the adipose tissue, and you can also have subclinical disease. So think of it like a disease of adipose tissue. We're endocrinologists, but BMI may be problematic because we need to look at Asians. You're looking at very low BMI, so we need ethnic-specific cut points. There's nothing wrong with that. And in terms of developing diabetes, of course, South Asians develop at a low BMI. And we should take that into consideration. Because say your BMI is 24 and you're all right, we say you have 24, but do you have any other risk factors? Do I need to look for any other problems in terms of diabetes, for example? And then BMI doesn't tell you about body fat distribution. Everybody says that, but it's really important to think about body composition at some stage, especially in individuals who are losing and gaining weight, especially with these new drugs. So when you lose weight, about 2/3 of your body fat is body fat and 1/3 is muscle. When you regain weight, that's all fat. So it's not unusual to see patients having 40% body fat, 45% body fat. These are individuals who cycled a lot over the years. So we need to pay attention eventually to body composition. Of course, fat deposition in the wrong place, liver and pancreas, is what drives diabetes. I'll skip this slide. So this is the debate that came across in terms of the Lancet Commission, and BMI can be problematic in athletes, but you can tell an athlete, can't you? You know that person, athlete, is not going to come to your diabetes clinic. That athlete is not going to come to your hypertension clinic necessarily. I learned the problem with BMI when I was an SHO. One of my colleagues came in and he had a black eye. I said, what happened to you? He said, I told this patient with BMI 32 that he had obesity and he punched me. And he was a big rugby player. So it's really important to take BMI into consideration in muscular individuals. But you can also have very high BMIs in sumo wrestlers, for example, who are very fit. But when they stop exercising and stop wrestling, then they gain that weight. So start with thinking about, is there a problem with excess adiposity? If there's a problem, then BMI is a really good measure to first look at it. And then after that, you can look at other measures. If you have the capability or the know-how to do it in terms of using body composition in terms of, you can use a bod pod as well, which my colleagues didn't talk about, which is body plethysmography that can be also used in pregnancy. But if you need to really ascertain what's going on in terms of body fat, why not do a DEXA? We do DEXA scans for bone density. Why don't we just do one to ascertain what's going on? But start with the BMI, then look at what other things are happening. I can tell you that here's data that I have. BMI is highly correlated with waist circumference, neck circumference, waist to height ratio. They're very highly correlated. And our first speaker presented a systematic review of measurements, and majority of the studies were BMI. So that's not going to change for a while. But if you, for example, suspect that there's a fatty liver problem, then why not go and do a fibroscan? Because you can do that very nicely. So this fibroscan shows that the higher the fat in the liver, the lower the quickie, which is insulin sensitivity, and the standard deviation CGM is higher. The fat is, and if you get people to lower their liver fat, they go into diabetes remission. So the ones that lower the liver fat are more likely to go into remission. So think about that question: is there a problem with adiposity? BMI to start with. Do I need to ascertain it more? Do I need to do more investigations? You might have to do an MRI if you suspect a lipid mass in the chest, for example. That's possible. That's the disease of adipose tissue. And then after that, stage the disease, and the different staging systems. We use the Edmonton staging system and as a King's obesity staging system. But what about the future? The future, your nurse is going to be a robot. You all remember Star Trek, you had your mobile phones, and this is what Dr. McCoy used to do, scan people and tell them exactly what's going on with them by just going around them and going shh. And they developed the first mobile phone. And now we have proteomic measures where you can actually see what happens to people in terms of glucose tolerance, liver fat, body fat percentage, visceral fat, and as well as physical activity. And then you can also look at the cardiovascular outcomes in terms of using proteomics. So using blood markers, you should be able to measure how much fat people have in the future. And additionally, you should be able to using markers to cluster people in different aspects of obesity, some who would end up developing cardiometabolic disease and some who won't. So to conclude, BMI is helpful for screening, but is not the final frontier. It's a good start. It's a good way to start the conversation. The investigation that you need to do is useful at population level analysis. What's happened to our population? Although I can tell you a story, in Saudi Arabia, they had levels of 15% childhood obesity based on International Obesity Task Force criteria. They changed it to Saudi growth charts, and they had 10%. So they actually solved their obesity problem by changing the cut point. So you have to get the right cut points to get the right level. Population-specific BMI thresholds should be used. So for India, I expect that tirzepatide should be used at a low BMI, and that's how it should be. Or change the way you do trials. In terms, there are no trials say we're going to have waist circumference or waist height ratio as the outcome. Currently, BMI is here. In the future, there'll be biomarkers, but use different approaches to get to the bottom of what's happening to your patients so you can give them the best advice. Thank you.